They are ready? I think they are ready in the operation theater. So,
Tanmay, are you ready there? Can you just
Yes, sir,
tell
we
us
are
a
ready.
brief about the case?
Yes, sir.
What is the age of the child and what procedure has been advised?
Yes, sir. Yes, sir. We are ready here. So, can you hear me?
Yeah. Just go
Okay,
through the case
I
history
will.
so that we can start the surgery
I'll
after
be
that.
presenting a short history. The parents presented with bilateral whitish opacity noting since late May, and they came here for further evaluation, and it was noted to have a cataract. So the first eye was operated in last week of June, and today the second eye is being operated. So the vision was following a torch light to both the eyes, and there was both the eyes was initially noted to have cataract, and as I mentioned, the left eye was operated. The USG of both the eyes were done. USG was okay, and the biometry was also done. So right now we will be shifting over to the OT for the surgery.
What is the age of the child, Tanmay?
1 year.
So the axial length is 21.6 as we saw from the slide.
Yes.
And what part of IOL has been selected?
For today's surgery, the 26 diopters has been selected.
26 diopters.
Yes.
So you said that the other eye has been pseudophakic already.
Yeah.
What I would be interested to know is whether or not a refraction has been done in the pseudophakic eye.
Yes.
And IOL had gone into the other eye. So that would perhaps, definitely help us to tweak the IOL power in this eye, because we won't like the child to be too hypermetropic at this age, because the near vision will be compromised. So has that been done?
Yes, the other eye has been refracted, and it was plus 2 diopters of hyperopia.
What was the power of the IOL which had gone in the other eye?
28 diopters.
Do we have a retinoscope? Streak.
Am I right, sir? Do you agree with me? The other eye should be refracted to know that what's the
I think that of course is very important. That raises the question: when will you do the second eye in a child? Some people are very aggressive and do bilateral simultaneous surgery in children, which I want to caution in children in particular. What is the targeted refraction that you decided when you put a particular power of IOL? And did you achieve that? And you want to make sure that that actually predictably happened, so you can make your mind up for the fellow eye. But more importantly, if you give a GA once, they need a washout time, and I'm told it can be neurotoxic or hepatotoxic, and you need a 1 month gap safe before you give a EUA or a GA for surgery. So 1 month is something I practice, and I believe Professor Jagatram also has taught us this for a long time. So I think it's important to know the outcome of the fellow first eye, and that applies to even adults also. Before you jump into the second eye, make sure what is the refraction. Did you get what you wanted or targeted? So that's a very good point. You brought it out. So I think it's already. Yes, Parikshit?
Good afternoon, sirs.
Parikshit, Professor Jagatram is watching you, and we all are very eager to learn from you. I know you have done. You are the master of this surgery. So please keep talking while performing this art.
Yeah, no. I think I can, sir. What we have done is we have given this child a small block. There is Dr. Bhattacharji here, who is the senior anesthetist, and we have intubated the child, and sevoflurane anesthesia is being given. But even after giving excellent intubation anesthesia, I have also given a 1 cc block, so that when this child comes out of anesthesia, I need a MVR side port. For some time, for about 60 to 75 minutes, there will be some block and there will be less pain. Now,
that's interesting, because if you're not covering that eye, you can have a problem. So you must be covering that eye patch.
Yes, sir. I give a patch, sir, always. And can I have a trypan blue? Yeah, so I would like to thank Dr. Partha, Monideepa ma'am, Priyam for this opportunity. I mean, I have always had two kind of icons for pediatric cataract surgery. So Dr. Vasavada sir and Dr. Jagatram sir. So operating before them is exciting but a bit intimidating. So we are just staining this, and I'll keep this for about 10 odd seconds.
Parikshit, now that we both of us are here, you mentioned, tell us what you should not have been taught to you. I'm sure we must have told you the wrong things now. So tell us now, this is where you should have taught me, you know. This is an opportunity, don't hesitate.
No, I think I've learned so many good things from you. And the first thing that you mentioned is that this is a team approach. Cataract surgery is just one important step in a series of interventions that are needed to give this child his vision back. Entry, visco ko 26 gauge needle lagana.
What is the viscoelastic that you just injected?
This is a high viscosity viscoelastic.
What is the name of that high viscosity?
What is the visco we have used?
Tell it, there's no issue about it. There is no legal people here. Helon GB, was it?
No, we have used HPMC only, no? Visco kaun sa use kiya?
What?
Viscoat we have used, sir.
Viscoat?
Visco, sir. HPMC, sir.
Yeah.
Right. The needle. ये क्या है? हाँ, तो विस्को को लगा के देना. अच्छा, इसको है. Okay. Now, this capsule is more elastic than adult capsule. So we have to be there is a very high chance that it can go astray. Can I have a Utrata forceps? No, capsulotomy forceps. So can you see my eye? Is it well centered? Is the illumination enough?
Yes, it's well centered. We can see it quite well. And incision, what you have used is 2.8 millimeter, I guess?
Yes, sir, 2.8 mm. They said here that we could even do it through 2.2, but since I'm doing it in a new place, I thought it's best to err on the side of safety. And I believe in suturing all my side ports and the main port, howsoever small, because the scleral rigidity is much less in a child. And
till what age do you do that, the side port suturing?
Sir, till 8 years, even 10 years, if it's a free surgery or if the child has come from a rural area. This child has come to Trenetralaya all the way from Jharkhand. So,
yeah, but that's, you don't want to say that. Of course, yes. Parikshit, you are doing so well, actually, so cool. And these capsules are so elastic, but you're managing it beautifully.
Thank you, sir.
And
I hope.
that also doing under methyl cellulose is really amazing. I can never do such a thing under HPMC. So this needs a very good dexterity and control. And also doing with cystotome all the time. That is even more difficult.
I'm going to need the Utrata.
You're doing well. I would have grasped the forceps, but this is superb. Very nice.
Well, I am also needing it, sir.
I think Dr. Gogate has done excellent job, because usually we use sodium hyalurate, because that will is also better, its retention is also better. And like him, we also stain the anterior capsule with the trypan blue dye. And once I think initial nick is made, complete the rexis, we complete the rexis with the Utrata forceps, because in such a case as this case, it is a high intralenticular pressure. In this case also, it is like that also. So we will not ask person till he complete the rexis, because it is not a simple case. It is a case where lens is swollen and intralenticular pressure is high. Although he has put adequate viscoelastic,
Yeah, I have seen Jagatram sir's video of the CCC be done like a protractor. So, saline.
I think excellent job. You have completed it.
Yeah,
we appreciate you.
You may not hear, Parikshit, but people are clapping here and they are almost giving a standing
No, but there seems to be a small extension when I have tried to do. Yeah, I want a IA, irrigation aspiration. Now, in a pediatric cataract, it is the anterior capsule and the equator from which the new cells are set up. So once we have taken care of the cataract, we should see to it that we polish the rim of the anterior capsule well, that we polish the vitrector, we polish the equator very well, because that is from where the new cells will be coming out. I will need, I think, can I have a side port again? Yeah, and a visco, please. Yeah, I think it just 2 minutes. I think we had done this, but let's see. Yeah. Also, we had done a study once about more than 10 years ago, the Miraj Paediatric Cataract study, in which we had looked at almost 7-year follow-up of cataracts, which were operated between 2002-2003 till 2007-2008. Till then, phaco perhaps was not a norm, so there were some surgeries which were done in the conventional way, which were done through manual small SICS. So I'm a great proponent of manual SICS, but this is one kind of cataract where phaco definitely is the best, because in phaco we can clean the capsules, we can polish the capsules really well, and that is what gives us the best kind of result in pediatric cataract surgery. Can I have a capsule polish mode, cap vac? Yeah, so now we are polishing the anterior capsular rim, because this is where most of the new cells are. Now, many surgeons say that you should make the anterior capsular opening as big as possible, but then as you can see, there is always a chance that it can go out and extend. Jagatram sir, Vasavada sir, so please give your valuable input, sir.
No, I think we are just so enjoying the skill that you are showing and the role that you have. The chamber is very stable, and you are able to move your probes without any giving any problems. So this is very good.
Now we have done the rim of the anterior capsule. Now we are doing the equator, because equator is the one where the cells are maximum. Now here, as you can see, my CCC has extended. So I'm keeping this for the last, because this is a chance that it may extend further, and we will not do much fiddling around there. Now, in the initial, both the sirs had said about what is visco removal karna iska. I can do it with the foot switch, no? Yeah. Is which lens to put in? Now the IOL power has come as 28. Visco, please. So we are putting in 26. So at this age, we would have perhaps done a 20% reduction. So if we wanted to make this child really emetropic, we would have perhaps thought of putting in, say, a 5 less, so about 23 the IOL. Upload kar do. Now, but the problem would have been the child would be very, very hypermetropic, about +4 or +5 for distance, almost +8 for near, which would not be good. So it's not a great undercorrection we have done, barely about 5 to 7%. So this child, when we do it, he will be just slightly hypermetropic, and because the child is less than 2 years old, as this child will grow, this child will become myopic at some point of time. But then even if the child is myopic, the child will be able to read, write, do all the near work, and nowadays, play on the mobile without putting on specs. And later perhaps we can think of a piggyback lens or a lens exchange. And God knows what technology is going to come in the next 10 or 15 years when this child becomes adult. Jagatram sir, anything else that can be done later? Visco, please. Visco.
About Lovins, I probably would have preferred a 25 in this case because 21.4 is the actual length.
Yeah.
And we don't have the keratometry with hand, and nor an on-the-table keratometry was done. So looking at that from the Dehan's point of view, I would perhaps be more comfortable putting in a 25, which would have less hypermetropia. The other eye already has a +2, so I would probably be keen to leave it at +1 to 1.5 range so that the near vision is intact.
That's another thing that Vasavada sir said, that parents are one of the most important partners in our treatment plan. So there we have to tell them that this child is going to need specs and need a 26 gauge needle with the Visco. Yeah, and this child would need bifocal specs because they think that the bifocal specs are only for, seniors, middle-aged people, grandparents. But because this child is going to have a different refraction for distance and near, unless the child becomes myopic for some time when they will need only distance one now. I'm just going in behind the lens, and now this is slightly the tricky part. But this is also a tip that Dr. Jagatram had given us once, that when we do this, we do it a vitrector rexis. Is the PC visible?
Yeah, absolutely, perfectly.
No, we can see very well, very clear.
You don't see very well. Okay, let's see if I can. Visco, please. Yeah. Only on retro. So how do I do that? Yeah.
Right now we are only on retro illumination mode. I hope the posterior capsular opening is visible.
Now generally I would do this smaller than the anterior capsular opening. About 3 mm is what I would do, not more than that. Is that correct, Vasavada sir, or should it be larger?
Yeah, the opening, we need a support and at the same time a clearer axis. So anything more than 2, 3, that is fine. But there are many ways of doing capsular axis. Before you put the lens in the eye, after you put the lens, and you're doing it so well, so elegant. And also doing it through a retractor, preferably to pars plana. So there are many ways, but as long as you know what you're doing and you understand, it's okay.
Yeah, normally I would, for many years now, I'm doing it after putting in the lens, because many years ago when we had this and I divided it, doing it before putting in the lens is easy, but when the lens unfolds, there is a small chance that, it can go in. Visco again, and I will need a vitrector now.
But sir, in a case like this where the anterior capsule is not very integral, both of your opinions, would you, even if you do it routinely before putting in the IOL, in a case like this, in a situation like this, would you prefer doing it after putting in the IOL just to give additional support to the anterior haloid face? would you prefer that?
I think, it really depends on your personal experience and expertise. There is no one answer to that. If I had this, I always believe that Rexis before the implant is a better idea.
Yes,
but
that's what we have.
based on my setup and skill and everything. But as long as I said, you can do many things, whatever you want to do. That's okay. And here also, the vitrectomy also can be done through different approach and different ways. But if you're doing one way all the time, you know the limitations of that and the advantages of that. So I think Parikshit is showing one option which he's showing is so well, actually. Excellent.
So for many years, not many years, at least for 5-6 years, we would do it through the pars plana, which makes it actually easier, because then the main port and the main incision and the anterior chamber, they are not at all disturbed. And as we always say that when we do a vitrectomy, there is this beautiful video of that wool being, pulled out, and if you do it from behind, it goes behind. But well, as anterior segment surgeons, again going through the pars plana is a bit time consuming. So I think it's more of laziness, or just because you have too many things to do, you do it through the anterior. Now I'm using a Centurion machine. It's a wonderful machine and the control is awesome. And as you can see, we have done a PPC, and here now I am not hydrating this. This is a trick that Dr. Jagatram had been telling us, that if we keep on hydrating, then the posterior capsule keeps on wobbling. Now the main thing is to see that the scaffold of the anterior vitreous is broken, so that there is the cells cannot go on it. Visco देना, इससे छोटा cannula होगा नहीं. Now we just want to see how much of the visco we have cleared. I can see the blob of visco that has gone behind the lens, which I will need to remove. And once that is done, put in an air bubble to see that things are well, that this lens is covered on all its sides except perhaps superotemporally by the anterior capsule. And once that is done, I think we are done with the surgery. So this here is where the anesthesiologist plays a very important role, because if the child is really very well sedated and if the anesthesia is good, then even without giving a block, the intraocular pressures are always less. The recovery is faster. Now here, of course, we have the Lumera microscope, the Zeiss Lumera. We have the Alcon Centurion. We have some of the best kind of equipment that is there to use. But suppose somebody is operating in a district hospital, a medical college, or a periphery, and we don't have such a high-end machine. Even then, if we keep the bottle height high, if we see to it that the intraocular pressure inside during the surgery is well maintained, that the asepsis is perfect, that the pre-operative evaluation is good, and most importantly, as Vasavada sir said in the beginning, the post-operative care is very good. I think we'll still be able to give a very good vision to the child. But
I think, Parikshit, you are doing a great job, and I believe now you will be removing OVD and suture the eye,
yes,
and that will be the end of the surgery. Is that
yes,
correct?
Sir. Yes, sir.
So I think we wish you all the best, and you've shown it so well. So thank you so very much, Parikshit, with the
Thank you,
time we
sir.
have.
Yeah,
wonderful way of showing this very important part of the surgery. So see you later.